So I'm going to speak about the results of the THESUS registry. THESUS registry has been published 2 years ago, and it's a sub-Saharan African survey of heart failure, and is the first and largest multi-center registry of acute heart failure in Africa to date, which has characterized the causes and the short-term outcomes in 1,006 African patients with heart failure from 12 tertiary cardiology centers and in 9 countries in sub-Saharan Africa. The diagnosis of heart failure in the THESUS was based on the presence of dyspnea associated with physical findings of congestive heart failure. So pedal edema, raised jugular venous pressure, pulmonary congestion, and or tender hepatomegaly, necessitating admission to hospital in patients who were 12 years or older. Echocardiography was used to demonstrate cardiac dysfunction in all patients who were entered into the study. So as I said, 13 university hospitals, 9 countries, 1,006, and this is the distribution. And I would like to take your attention, for example, Nigeria, as in these 1,006 patients has entered with 4,030 patients, and some countries like Ethiopia, who came late in the study, only had 10 patients, or Senegal, who had only 15 patients. Most of the countries had around 100 patients, like for example South Africa with 2 different centers. And these are the data. The mean age, as I said today in the morning, was 52 years. We are speaking about a continent with a very poor continent. The distribution in gender was more or less half for each one. Most of the patients were black, and the mean left ventricular ejection fraction was around 40%. And systolic dysfunction was found in 70% of the patients. We have considered 2 different causes of heart failure, the endemic ones and the emergent ones, and we call emergent ones the new ones, the hypertension, which was the main cause of heart failure in this registry, 40%, ischemic heart disease just about 8%, and other emerging just 3.5%. The endemic causes, rheumatic heart disease was the second cause of heart failure with 15% of the patients, idiopathic dilated cardiomyopathy 13 or 14, peripartum cardiomyopathy about 8, pericardial effusion, most of them TB related, about 5%, and other endemic, HIV 2.4, and endomyocardial fibrosis 1.3. This is another way of showing it. So in the emergent causes of heart failure, hypertension was by far the most important one, and ischemic heart disease a very small percentage of patients. And in the endemic causes, dilated cardiomyopathy, rheumatic heart disease, peripartum, pericarditis, HIV, and endomyocardial fibrosis. The next slides are going to be about a little bit complicated to read, but nevertheless, let me just stress some things. The age is a very young age. We are speaking about a population of around 50 years old. Risk factors for ischemic heart disease are not very frequent. Only 9.2% of the patients had hyperlipidemia. 9.8% of the patients had a previous history of smoking, with 2.6% in women and 7.3% in men. But very high rate of hypertension, around 55%, and the people were not so obese. So the body mass index was 25.2 mean, and a little bit more in women as in men, as usual in Africa. High entrance systolic and diastolic blood pressure, because most of these patients were hypertensive patients. and a very low rate of diabetes, around 11%, much less than the 60% of the study presented before. Going to other clinical data, so the biochemistry values, just let me stress the mean hemoglobin was 12.2, a little bit less in women than in men. Cholesterol levels, and this is in milligrams per deciliter, 157.6. And another thing that Pico said this morning, only half of the patients have been tested for HIV, and among those that have been tested, we had 6.6% of positive patients and 43.9% of negative patients, but just half of them have been tested. So maybe the prevalence of HIV-related or pathology on HIV patients were more than the one that we have reported. So as I said before, we have further analyzed the data in terms of endemic and emergent causes of heart failure. Endemic were the ones that we have been used to see in Africa for a long time: rheumatic heart disease, dilated cardiomyopathy. HIV is not so old, but we call it endemic, tuberculosis and endomyocardial fibrosis, and we included in the emergent causes hypertension and ischemic heart disease. And if we compare these, we will see that the mean age of the emergent causes is higher than the endemic causes, as supposed to be, and significant. Also, the total cholesterol is bigger in the emergent causes than in the endemic causes. Smoking is equal. Hypertension is, as per definition, is more prevalent in the emergent causes. Type 2 diabetes also. The patients were, most of them in class 2, some in class 3, and a few in class 4. And systolic blood pressure and diastolic blood pressure was for sure more prevalent, higher in the emergent causes, because hypertension was included in this subgroup, and nothing else to speak about. These are the data from the echo, comparing again endemic and emerging causes of heart failure. And it's very interesting because the ventricles are bigger in the endemic, because here you've got the rheumatic heart disease, dilated cardiomyopathy. Also, the ejection fraction is more or less the same. There's no difference. The ventricles are thicker in the emerging causes because of hypertension. And left atrium is bigger and significantly bigger in the endemic causes, because we have here the left atriums of endomyocardial fibrosis, dilated cardiomyopathy, rheumatic heart disease, and so on. ECG. The ECG was available just for 814 patients, and these are the main data of the ECG. The mean ventricular rate was 104 beats per minute. Atrial fibrillation was found in 18% of the patients. Left anterior hemiblock in 17.8. Complete left bundle branch block in 7.7. Right bundle branch block 4.9. Left ventricular hypertrophy by ECG criteria was found in about 28% of the patients, and right ventricular hypertrophy just in 1% of the patients. I put this slide again to show you again, to remind you again that some countries have just put very, very small numbers of patients. So this analysis of the etiology by country has a bias. I mean, we cannot compare the population that has been introduced by Nigeria, 400, with 10 patients from Ethiopia, for example. But I just would like to stress that ischemic heart disease is probably more prevalent in Kenya. Kenya was a private hospital, and this is also a cause of bias probably in this population. Sudan, that we have discussed this morning, with 72 cases, has a high prevalence of ischemic heart disease. So I think that there are different pictures of epidemiological transition in all these countries, but at the end, with 1,000 patients, we have really very few cases of ischemic heart disease. This is the pattern of treatment. So 4 columns at admission, at discharge, 1 month after, and at the end of 6 months for each drug. ACE inhibitors were prescribed for almost 80% of the patients, as well as the loop diuretics. The big beta blockers, well, they increased at the end of the 6 months, around 40%, but still not very high rate of prescription of beta blockers. Digoxin, around 50%. The association of hydralazine and nitrates in a black population, mainly secondary to hypertension, which should have used more this association, was really not used. Aldosterone antagonists, about 60%. Statins, less than 20%. An unusual high rate of prescription of aspirin, and anticoagulation, about 20%. The outcomes, so the length of initial hospitalization was 9.2 days. Mortality at the hospital, 4.2. Readmission till the end of the 2nd month, 9.1. Death to the day of 2nd month, 10.5. The combination of death and readmission to the end of the 2nd month, 15.4, and the death rate to the end of the follow-up, which was 6 months, 17.9%. These are the results of univariable and multivariable models for death and rehospitalization till the end of the 2nd month. This is on the left side, the univariable, on the right side, the multivariable, and as you can see, white blood count, blood urea, heart rate, peripheral edema and malignancy were associated with a bad outcome, and diastolic blood pressure was associated with a good outcome. For the death at the end of the 6th month, multivariable Cox model showed that white blood count, creatinine, peripheral edema, malignancy, and HIV was associated with a poor outcome, and systolic blood pressure was associated, as expected, with a good outcome. These are the Kaplan-Meier curves of, on the left, all-cause death and readmission at the end of 60 days, around a little bit less than 20%, and this is mortality at the end of the 6 months, that was about 20% also. So in conclusion, we say that in Africans, acute heart failure has predominantly a non-ischemic etiology, most commonly hypertension. There is low use of beta blockers, hydralazine and nitrates, and inappropriate high use of aspirin. The condition occurs in middle age. Heart failure is associated with high mortality, especially in patients with HIV infection. Later this year, Karen Sliva and Bongani Mayosi have published this paper in The Heart, comparing the registry in the United States with the one in Europe and with our own. And as you can see, in Europe, a little bit more women, but otherwise it was the same. We have the lower age of the registries. We have also the lower rate of hypertension, much lower rate of ischemic heart disease as was expected, low rate of diabetes, low rate of atrial fibrillation. Our population is still young. Anemia was the same as in Europe, and a low rate of renal insufficiency. Another analysis that can be done, and that was done in the same paper, was to compare what happened in Africa from 1957 to 2005, compared with now from 2007 to 2010. What we see is that there is an increase of hypertension as a risk factor for acute heart failure. There is already a decrease of rheumatic heart disease. Cardiomyopathy increased, probably because also we have used the echo, which has not been used in most of the studies done before. Pericarditis have increased, and this is probably related to the HIV epidemic, and ischemic heart disease, although still not important, has increased almost 4 times. And this is the team. So this was a multi-center study, and this was extremely important because it created the network that went further with other studies, and that is now in place. And I think is very important for the studies in Africa. And I thank you for your attention.